Good afternoon. This is Dr. Kyriakos Kirou. I'm a rheumatologist at the Hospital for Special Surgery and the director of the Lupus Nephritis program here. Today, we're going to be talking about an update of lupus nephritis, and I would like to say that I do not have any pertinent disclosures except that I have been part of several clinical trials in lupus and lupus nephritis. Also, I would like to inform you that what you hear today is only to educate you and should not be used for specific therapeutic advice. You should talk to your physician about getting specific advice for your problems. Today, we're going to talk about several issues, and here is the outline. We're going to discuss what is lupus, lupus nephritis. We'll briefly talk about the anatomy and function of the kidney. We'll talk about how we make the diagnosis of lupus nephritis, what tests do we use. We're going to briefly discuss the classes of lupus nephritis, the treatment of lupus nephritis. We're going to also talk about the kidney function trajectory in health and disease, in this case, lupus nephritis. We will also discuss the fact that there is an unmet need for the treatment of lupus nephritis at this point. There are some interesting developments with new drugs approved for lupus nephritis. We're going to talk about potentially other treatments as well. And we will also discuss treatment of comorbidities in lupus nephritis and the goals. What are our goals when we're treating this disease? So lupus is a disease of young or middle-aged women. About 1 in 1,000 women might get this disease. It's predominantly a female disease, and you can see the ratio of female to male is approximately 9:1. It is more frequent and often more severe in non-Caucasians. The most common symptoms of lupus include joint pain, stiffness in the morning, and swelling. Specifically affects the hands and wrists. We can also get skin rash, especially after exposure to the sun. This is what we often call the butterfly rash, and it's on the face. Sometimes patients will get chest pain when they take a deep breath. This is because of inflammation around the lung and the heart, and it's called pleurisy or pericarditis. When lupus nephritis happens, we often get swelling of the legs. We call this edema. Less common symptoms include muscle weakness, low blood count or anemia, easy bruising because the platelets might be low. Blood clots is another rare complication, especially with antiphospholipid syndrome. And then rarely also we can get seizures, psychosis, or a stroke. So lupus is a systemic autoimmune disease. Systemic means that it can potentially affect all body organs and tissues. Autoimmune means that the immune system, instead of fighting infections and tumors, it starts to attack body tissues. Genetic problems, sunlight exposure, hormonal reasons, and infections may be the reason for this immune system dysfunction. Autoimmune B lymphocytes produce autoantibodies such as anti-nuclear antibodies, we call them ANAs, anti-double-stranded DNA antibodies, anti-Smith and antiphospholipid antibodies. We often use these as a test for the diagnosis of lupus. Autoantibodies, what they do is they bind self-particles like DNA, for example, and other cell proteins. The complexes they form, we call them immune complexes, and they travel in the blood circulation and go to different organs. There, they deposit and cause inflammation by different mechanisms, including activation of complement factors C4 and C3. Physicians check C3 and C4 levels because they can get activated. When they get activated, they break down to smaller pieces and the levels go down in the blood. So that can inform about how active is the disease. So what is lupus nephritis now? Lupus nephritis is the most frequent or important, you can argue, organ involvement in lupus. Up to 30 to 50% of lupus patients may develop nephritis, usually within 3 years from the diagnosis. Inflammation in the kidney causes protein leakage in the urine. We call this proteinuria. Leg swelling, the edema, and worse kidney function. We measure this by the serum creatinine level or the glomerular filtration rate, GFR. Lupus nephritis tends to come back even after it gets better. We call those flares. Repeated flares cause scarring in the kidney, and that sometimes is not reversible, so we have to be careful about flares. Up to 20 to 30% of patients with lupus nephritis may develop renal failure and require a kidney transplant or dialysis at some point. Only rarely lupus nephritis can happen again after kidney transplantation. This is how the kidney looks. We have two of them, and they look like a bean with a cortex part, the medulla part, and then the calyx, renal pelvis, and the ureter. That's where the urine flows eventually. Here is a close-up view. You have a piece of kidney here that is magnified, and we see the units of the kidney function. Those are called nephrons. So you see the nephrons here. So they start by like a structure that's called glomerulus. It's a round structure containing small capillaries. The blood comes here, it gets filtered in the urine, and then what is the clean part returns back to the circulation. So what is filtered goes through the tubules and finally gets excreted in the urine. So how can we diagnose lupus nephritis? What are the symptoms and signs? Sometimes it's the high blood pressure. Some patients will feel this as a headache. So high blood pressure is one of the signs that can alert us that something may be wrong in a patient with lupus. Swelling of the feet or the eyes, that's the fluid overload that happens with kidney dysfunction. Nocturia means sometimes patients will get up too many times in the night to urinate. Frothy urine that contains bubbles. You can see this here with all this froth on the top of the urine. Sometimes there may be no symptoms at all. So it's important for us to check the urine in patients with lupus so that we can be able to detect earlier a problem. Of course, none of this is specific. We have to make sure there are no other causes that can do the same, can produce the same symptoms. For example, menstruation can cause blood in the urine. A UTI can cause abnormalities, a kidney stone, and so on. What are the tests that we should be looking at when we're dealing with a patient with lupus nephritis? First, we want to know about the kidney function, and that we can tell by looking at the serum creatinine. It's normally below 1 in an average woman, and maybe a little higher in muscular men, as this reflects also the muscle mass. So it's not a clean test just for kidney function. Albumin is a very important protein in the blood, and when it's leaking in the urine, it will become lower than the normal, typically lower than 3.5. We look at sodium, potassium, which are electrolytes. We also look at lipids. Cholesterol can go up sometimes when you have very high amounts of proteinuria. We can also look at glucose just in case there is diabetes or the sugar goes up because of steroids. And we also want to look at vitamin D, which is important for the bone. The estimated glomerular filtration rate, or otherwise eGFR, is calculated based on the creatinine, age, and gender of the patient. It's normally between 90 and 120 in a healthy person. We also look at the complete blood count to check for anemia or low white cells or low platelets, because these are important to know when we treat a patient with lupus. We want to exclude exposure to tuberculosis. We do a PPD skin test, a quantiferon blood test, or we also check in the blood for evidence of hepatitis B, C, or HIV exposure. We often do a urinalysis. We should do that all the time, actually, to check whether there's protein. Normally it's 0 to trace, and whether there's blood, red cells, or white cells. We also do a 24-hour urine protein collection, and that helps us measure exactly the amount of protein in the urine. If the protein in the urine is more than 3,500 milligrams per 24 hours, we call this nephrotic range proteinuria, and it's more significant. It indicates more severity of the disease. Sometimes we also do a spot urine protein and creatinine ratio. So a single specimen, we look what's the amount of protein divided by the creatinine, and this gives us an estimate of the proteinuria. We need to do often a renal ultrasound to make sure there's nothing like flow obstruction, for example, from a kidney stone, or is there already a lot of scarring from, or there's another kidney disease. The kidney biopsy is probably the more important test that we have to do when we diagnose lupus nephritis. It helps confirm the diagnosis and exclude other causes. It helps establish the class of lupus nephritis, and we're going to talk about that in a second. And it also helps assess the amount of activity or inflammation. This is the reversible part of kidney disease. We can get it better, as opposed to how much chronicity or scarring is there. And that's irreversible often. We cannot reverse that. We can tell those by something called activity and chronicity index. What are the risks for the kidney biopsy? It's usually a low-risk procedure. People can go in the morning and go home the same day without, usually there's no complications. Rarely, there may be bleeding outside of the kidney, usually mild, but in that case, we monitor the patient sometimes overnight. And the procedure is done by putting a needle under imaging. So they do a CT scan or an ultrasound so they know exactly where they put the needle. And they take a very tiny piece, like a tube-like piece within this needle, very tiny, for the microscopic analysis. We are very careful to have the blood pressure well controlled and stop anticoagulants before we do the biopsy to minimize this bleeding risk. So these are the classes of lupus nephritis. Class 1 and 2, they're usually very minimally severe. Class 3 and 4 become more significant. Now you have more cells that infiltrate the kidney. We can see congestion of the kidney. I'll show you a picture of that. And that can often lead to loss of kidney function early on. We can also get something called membranous lupus nephritis, class 5. Class 5 doesn't mean it's worse than class 3 or 4. It just indicates a different type of involvement, where only the membrane and not the whole glomerulus is affected. And finally, we have class 6, which indicates sclerosing disease, just the scarring part without inflammation anymore. So a patient could have either class 3 or 4 lupus nephritis. They could have also class 5 alone, or they may have a combination of either class 3 or 4 plus class 5. So class 3 or 4 nephritis, with or without class 5, is worse than class 5 alone because it often affects the kidney function, as we indicated. That requires usually more aggressive treatment to restore kidney function. Class 5 nephritis, the membranous type, without presence of the 3 or 4 classes, causes primarily proteinuria without affecting the kidney function in the beginning. So that's probably easier to treat, although it can be more severe when it has heavy proteinuria, nephrotic proteinuria. And this can cause significant leg edema. The legs can get very swollen with this, high cholesterol, and sometimes it can cause blood clots. So again, when this happens, the high level proteinuria, we have to treat also more aggressively. So under the microscope, this is how the glomerulus looks. Remember, this is the round structure of the unit of kidney function. And all of these open circles here is the blood vessels. And they're open because there is no blockade. The blood can go through them very easily. So that's a normal kidney. Look at this. This is the, on the right side, we have a kidney, a lupus nephritis patient with a glomerulus there. And now you can see that there is congestion. We don't have these open spaces anymore. The capillaries, the blood vessels, the small blood vessels in the glomerulus are now congested with cells and they cannot function well. So how do we treat lupus nephritis? We normally talk about two phases of treatment, initial or induction phase and maintenance phase. The initial or induction phase usually takes place within 3 to 6 months. The goal is to substantially improve the kidney function and proteinuria while decreasing the steroid dose. The induction treatment regimen typically includes steroids. Usually we do an intravenous infusion of methylprednisolone. We call this a pulse dose because it's a relatively high dose of steroid for 1 or 3 days, up to 3 days. And then we follow by oral steroid, usually prednisone. This is not enough. We also have to prescribe mycophenolate mofetil, which is an immunosuppressive medication by mouth, or intravenous cyclophosphamide, which is a low-dose chemotherapy medication. And we often use something called hydroxychloroquine, which is a relatively mild medication and not very strong, but in combination with the other medications provides additional help. This treatment regimen is not the same for every patient, and it will be determined by the treating physician after discussion of each medication choice with the patient. Some other medication choices might include azathioprine instead of mycophenolate, and etc. So the maintenance phase follows the induction phase. Now we hopefully have made some improvement in kidney function, and this can go on for 3 to 5 years usually. The goal is to stabilize the kidney function and allow for further improvement of proteinuria while preventing new flares of nephritis. Typically, the maintenance treatment involves, again, oral steroids, but now low doses. We try to keep the steroids low, try to go below 7.5 milligrams per day, and sometimes we're able to stop it. That way, we can minimize the side effects that sometimes we get with steroids. We also need, again, something else. We need the mycophenolate mofetil or azathioprine as immunosuppressive medication. And again, we need the hydroxychloroquine unless there is a contraindication. Again, this is not standard for everyone. It can be tailored to the needs of the individual patient after discussion with the physician. So we already mentioned that medications can have side effects. We want to minimize them while getting the benefit in the lupus nephritis. So steroids like prednisone can increase the risk for infection, weight gain, high sugar, especially in somebody who already has diabetes. The blood pressure might go up, so we have to be careful with that. It can cause osteoporosis, so we check for bone density testing sometimes to be sure, osteonecrosis or lazy adrenals. The adrenals is where the body steroids are produced, and they can get lazy after a long course of steroids. So when we taper the steroids down, we need to make sure that the body adrenals work again to take over after that. Steroids can also cause thinning of the skin and easy bruising. They can also cause cataracts in the eyes and other side effects. Cyclophosphamide, this is the chemotherapy we talked earlier, can cause nausea, can increase risk for infections such as pneumonia or shingles. It can cause infertility when somebody gets repeated doses of cyclophosphamide. Low blood counts, transient hair loss. This is something that recovers. And it's contraindicated in pregnancy because it can cause teratogenicity. Rarely, it can also cause inflammation of the bladder or bladder cancer or leukemia. These are very rare. Mycophenolate can cause nausea, diarrhea, low blood counts. Also, infection is part of this. And again, contraindicated in pregnancy. Azathioprine can cause very similar side effects, but has no issues with pregnancy. So sometimes we prefer it just for that reason. Hydroxychloroquine can cause nausea, skin hyperpigmentation sometimes, and very rarely retinal toxicity, which we try to prevent by having the patient checking with the eye doctor frequently and stopping the medicine if we see any signs of this happening. This slide is to emphasize that the kidneys are very sensitive organs, and they're not like the liver that can regenerate. So in a healthy person, the kidney function will gradually drop over time. So you can see here with the black line, when somebody's 20, they have a glomerular filtration rate, GFR of 120, which is normal. But as the person gets older, at 40, at 60, this becomes 100. And if somebody lives up to 100 years old, this may be 40, 50, or 60. So much decrease from the beginning. This is not enough to get somebody to dialysis or kidney failure unless there is something else. And in this case, for lupus, we worry about lupus nephritis flares. So if somebody gets a lupus nephritis flare and it's not treated well, they may lose a little bit of kidney function right away. So within a few years now, we have a new starting point of 70 here. And this, if it doesn't, if it could potentially progress and lead eventually to kidney failure if somebody lives to be very old. Now, if somebody keeps getting attacks of lupus nephritis, this may happen earlier. So it's very important to prevent or treat very early, so we kind of keep the line going this way and not the other direction. So unfortunately, despite the treatments that I already showed you that we have available for lupus nephritis, we're not very happy there. We still have way to go to get the results we want. So in one large lupus nephritis study with 370 patients, only about half of the patients had a partial response in 6 months. So partial response means stable or improved kidney function and decrease of the proteinuria by at least half to levels below the nephrotic range. This is the very severe proteinuria. We want to get below that. So about 50% did it only. The study compared mycophenolate and cyclophosphamide and found no difference in the two groups. This was the ALM study published in 2009. Now, in the same study, even less patients, only 25%, achieved levels of proteinuria that were close to normal, below 500 milligrams per day at 6 months. So that's not what we're looking for. We need better results. So maintenance treatments are also not great. So the same study, patients who had this partial response, 227 of them were eventually treated with either mycophenolate or azathioprine for 3 years. About 16% of the mycophenolate treated patients and 32% of the azathioprine treated patients did not do well, had another lupus nephritis flare, 13 and 23%, worsening of their kidney function, or another bad outcome. That was also published in the New England Journal of Medicine in 2012. So fortunately, there is progress. Some of you may already know about belimumab. This is a new drug approved by the FDA for lupus in 2011 and pediatric lupus in 2019. It's a monoclonal antibody that blocks BAFF, which is a growth factor that promotes survival and differentiation of autoimmune B cells. These are the B cells that produce these autoantibodies that can cause trouble with lupus and lupus nephritis. So the name of the study was BLISS-LN, so BLISS lupus nephritis, a large study with 448 patients, phase 3, randomized double-blind placebo study. Patients were treated with standard treatment, so that would be steroids and mycophenolate or cyclophosphamide. That was followed by azathioprine. And they got either IV belimumab or placebo, which is a fake drug, for two years. So patients who were treated with belimumab did better. So 44% of those, as opposed to 32% of the placebo patients at 2 years, had proteinuria below 700 milligrams per gram of creatinine. So approximately, let's say, less than 700 milligrams per day. They had stable kidney function and no need for rescue treatments or other treatments in addition to the study treatments. Patients with nephrotic range proteinuria benefited a little bit less with this treatment. This study led to approval of belimumab for the treatment of lupus nephritis in 2020. There is another study that was approved in lupus nephritis recently. That's the voclosporin medication. It's an oral medication that blocks calcineurin, which is an important enzyme in immune cell activation. This and other medication of this family of calcineurin inhibitors, they include also tacrolimus and cyclosporin. They also protect from damage the podocytes. These are important cells in the kidney filtration unit. So we want to keep them safe and working well to prevent leakage of protein. So voclosporin was studied in the phase 3 Aurora study. This was a large study, 357 patients, phase 3 randomized, double-blind, placebo-controlled like the previous one. Patients were treated with standard treatment, steroids and mycophenolate, and received either the drug, voclosporin, or placebo for a year. Patients treated with voclosporin had better complete renal responses, 41% of them, compared to placebo, which was only 23% at 1 year. And here we mean proteinuria very close to the normal level of protein, below 500 milligrams per day, stable kidney function, and no need for rescue treatments, and no prednisone more than 10 milligrams. So this is, again, very promising. And the drug was approved for the treatment of lupus nephritis in 2021. There are other drugs used for lupus nephritis. They include those other calcineurin inhibitors, tacrolimus and cyclosporin. They include rituximab, which is a medication that kills and depletes the B cells. Although this drug is not FDA approved, is considered very effective in combination with the standard treatment of lupus nephritis by many experts. Other drugs that are now tested to see how they will work in nephritis include obinutuzumab, which is a similar drug to rituximab, but more potent. We have promising early results for this medication. And also there are several other medications under study now for lupus nephritis, which is very promising that soon we'll have other effective treatments and we will fulfill that need for effective treatment of lupus nephritis. We should also briefly discuss comorbidities here. Okay, so we want to be changing our lifestyle towards more healthy habits, good hydration, quit smoking, body weight optimization, exercise, avoid the sunlight, which can cause lupus flares, avoid alcohol, avoid non-steroidal anti-inflammatory drugs such as ibuprofen, naproxen, etc., because those can affect the kidney function. We also want to be cautious if anybody recommends IV contrast for, let's say, a CT scan or an MRI. We have to tell the doctor we have a kidney problem. Blood pressure control is very important, and proteinuria also needs to be controlled very well by avoiding salt. Use antihypertensives, specifically the angiotensin-converting enzyme inhibitors, such as lisinopril, benazepril, and so on. Angiotensin receptor blockers, such as losartan or valsartan. All these drugs in the same family can do that, can reduce blood pressure and can help the proteinuria significantly. The diuretics can help us get rid of the extra fluid in our legs. And there are other blood pressure medications that can be effective, such as beta blockers, etc. We want to avoid dehydration or too low blood pressure. So the blood pressure should be optimal, not too low, not too high. If somebody has dehydration, for example, from diarrhea, they may need IV fluids. They need to contact their physician. We need to be careful about our bones because steroids like prednisone can affect the bones. So we want to have optimized calcium and vitamin D3 levels, and sometimes we will need bisphosphonates such as alendronate to help our bones, not lose density. We want to be careful about cholesterol because often it goes very high and may be implicated in heart disease. So we want to consider statins, for example. We also need to have contraception counseling. We need to avoid pregnancy during active lupus nephritis because it's very risky for the mother and the child. We usually want to wait for at least 6 months when the disease is very quiet before we consider pregnancy. We want to talk about risk of infection, screen for previous exposure to hepatitis, HIV, or tuberculosis. Sometimes we need prophylactic antibiotics, especially when somebody will get the chemotherapy drug. And we also need to consider vaccinations for influenza, pneumonia, COVID-19, but we need to avoid live vaccinations. The goals of treatment for lupus nephritis, therefore, are as follows. We need to treat early and aggressively in order to minimize proteinuria and scarring. Therefore, sometimes we need to consider drug combinations early on, if appropriate. We will hear soon, I believe, new guidelines from the rheumatology and nephrology societies regarding using more aggressive treatments for lupus nephritis. We also need to consider new and promising clinical trials, again, because this is a field that is evolving and we hopefully will do better in the future. So we need patients in clinical trials to find better cures. We need to prevent lupus nephritis flares and treat them as early as possible to prevent scarring. We need to reduce steroids and taper them off if possible, if this is appropriate. And this varies from patient to patient. The physician will advise you regarding this. We need to treat comorbidities such as high cholesterol, high blood pressure. We need to prevent complications and prevent adverse effects of medications such as osteoporosis, weight gain, infections. The most important part of this is the partnership between the physician and patient. The choices have to be taken together, the decisions, they need to work together, communicate often in order to have better results. And also we need close collaboration of rheumatology sometimes. Also, we need nephrology, and we also need the kidney biopsy, the renal pathologist, to discuss the findings, and other subspecialists like a cardiologist or other subspecialties that may be very important for us to treat successfully a patient with lupus. Thank you very much for watching this presentation today. We are here from the Lupus Nephritis program at HSS. We work under the Lupus and APS Center of Excellence, and we collaborate very closely with the New York Presbyterian Cornell Nephrology and Kidney Pathology departments. Thank you very much.